Um, and actually, again, we're going to start with our early stage investigator CFAR seminar. And I'm going to turn it over first to Peter to introduce Diana, and then Diana will be introducing you. And then at the end, we'll have time for questions for you, and a number of clinicians and researchers on this call who grapple with the questions that you're going to be talking about, which is weight gain with antiretrovirals every day. So thank you again, Paul. Thank you.
Yeah, thanks. Thanks for inviting me. It's an honor to be invited.
Thank you for being here for our CFAR seminar. Go ahead, Peter. Thank you.
Thanks, Monica. So it's my pleasure to introduce our ESI speaker of the day, Dr. Diana Alba. Dr. Alba got her MD from New York Medical College and then completed her internal medicine residency at University of Miami, after which we were fortunate enough to get her here at UCSF for endocrinology fellowship. During her fellowship, she joined Sunil Koliwad's laboratory and began a translational research program focused on the mechanisms by which adipose tissue dysfunction and fibrosis might contribute to insulin resistance and diabetes, providing novel mechanistic insights into why people from some racial ancestries develop diabetes at lower BMI than others. As some of these same pathways may be operative in HIV, she has led a series of studies with Sunil and I exploring the inflammatory and adipose tissue specific pathways that contribute to diabetes risk in treated HIV infection. She'll share some of that work with us today. She's a rising star in our field and was recently awarded the prestigious Robert Wood Johnson Foundation Harold Amos Career Development Award. Please join me in welcoming Deanna. We look forward to your talk.
Thank you, Peter. Let me share my screen. Okay, can you all see my screen okay?
Yep.
Great. Okay, well, good morning, everyone, and thank you for the invitation to speak today. And my title is, my talk is entitled Insulin Resistant and Diabetes Risk in Treated HIV, the Contribution of Adipose Tissue Fibrosis. So again, I'm an endocrinologist here at UCSF, and for the last couple of years, I've been studying obesity associated adipose tissue dysfunction with a particular focus on ethnicity-associated risk to metabolic diseases. And so to set the stage, diabetes is extremely common in treated HIV infection. And so these are data from the NA Accord study, over 20,000 people initiating antiretroviral therapy in North America from 2007 to 2016. And as you can see here in the plot is that regardless of your HIV regimen, it is about a 1% incidence of type 2 diabetes, which is really striking. It's a really striking high incidence of diabetes, and it's actually significantly higher than the general population in North America, which is about 0.7%. And the incidence increases to about 2% per year in people over 50. So again, very high. And yes, there are some differences between the HIV drugs, but the take-home point is that people living with HIV have an increased risk of type 2 diabetes regardless of the regimen. And as you can see here, the differences between the regimens are relatively modest. So most of you are probably aware of this classic concept of progression from obesity to type 2 diabetes, right? So there is, genetic and environmental factors that spur the process along, but it's basically the idea that it's a process that begins with obesity, and in certain people, it leads to insulin resistance, beta cell failure, and the development of diabetes and the loss of glucose control. However, not everyone who's obese actually develops type 2 diabetes and insulin resistance. And the idea is that the central fat distribution, in particular within the viscoadipose tissue depot, in this like apple shape or under distribution, is generally associated with worse outcomes or a worse metabolic phenotype, greater inflammation and insulin resistance, and an increased risk for type 2 diabetes and cardiovascular disease. This is compared to those people or the people who actually increase more their subcutaneous fat depot, which is considered to be somewhat protective. And so the question is what actually drives this viscoadipose tissue expansion and the consequent insulin resistance and type 2 diabetes. And so what's important to know is that the expansion of white adipose tissue in response to caloric excess occurs through either adipocyte number increase, which is hyperplasia, which is considered more a healthy expansion, or the enlargement of existing adipocytes, something called hypertrophy. And hypertrophy is considered to be more a pathological expansion of the adipocyte that actually has been associated with local inflammation. And this inflammatory response can lead to hypoxia and fibrosis, as well as the early onset of insulin resistance. And so this adipocyte dysfunction leads to spillover of lipids into non-adipose organs, something termed lipotoxicity. And this leads to metabolic stress and ectopic fat accumulation. So you have fat going to the liver, the skeletal muscle, heart, and the visceral fat depot. And so normally you need a lot of obesity to drive this fibrotic process in type 2 diabetes. But if you have another driver inflammation in adipose tissue like HIV itself, and there were other drivers of inflammation, it could possibly contribute to fibrosis even at a lower BMI. So the question is, might inflammation despite ART increase adipose tissue fibrosis and increase the risk to type 2 diabetes even at a lower BMI? And so we know that immune activation and inflammation persists despite viral suppression. But inflammation also predicts diabetes. And so this data is from a case cohort study in collaboration with Peter Hunt, where we set to understand the immunological predictors of type 2 incidence during ART-mediated viral suppression. And so we randomly selected samples from more than 800 participants from the cynics cohort. These are people without prevalent diabetes, but on suppressive ART for at least 12 months. And using a Cox proportional hazard modeling, we evaluated the relationship between biomarkers measured at 1 year of viral suppression and the risk of incident type 2 diabetes. And this was adjusted for age, natal sex, BMI, and hepatitis C. And so as you can see here, there's a substantial number of these inflammatory biomarkers that predict incident type 2 diabetes, including KT ratio and soluble CD163. And I'll come back to that later. So from the last slide, bottom line is that inflammation seems to predict incident type 2 diabetes. So how might inflammation actually mediate an increased risk of insulin resistance within the adipose tissue, which is thought to play a very important role? And so we wonder whether people with HIV actually might have increased fibrosis as a consequence of this inflammatory state. And so in our current study, we enroll this cohort of people with and without HIV and without type 2 diabetes, but we actually stratified this group by A1C to actually get a dynamic range of insulin resistance. And so we can actually evaluate the relationship between these various indices of insulin resistance or insulin sensitivity and allow for prospective studies for incident type 2 diabetes. So this is actually a very well-characterized cohort that includes DEXA scan data. We have abdominal MRIs, oral glucose tolerance tests, and ideally future studies are gonna link all of these measurements together. And so in this cohort, we actually collected abdominal subcutaneous adipose tissue samples using a mini liposuction technique. And we found that people with HIV actually have higher levels of fibrosis measured by hydroxyproline content in the lipoaspirates. And again, they have higher levels of fibrosis compared to people without HIV. But actually what's even more interesting is that we actually divided the groups by BMI using a cutoff of 30 to mark obesity. And we found that people with HIV have significantly higher levels of fibrosis, particularly among the lean people who aren't supposed to have much fibrosis. So in the HIV negative population, you only get fibrosis when you're obese, but in HIV, in fact, you already have fibrosis even when you're lean and you don't have much fat. And so as I mentioned earlier, many inflammatory pathways predict incident type 2 diabetes. And some of these pathways are immunoregulatory to inflammation that have actually been linked to fibrosis. So soluble CD163 is a marker of empty macrophages, which tend to be more pro-fibrotic. And KT ratio is a marker of IDO activity, which induces regulatory T cells, which can actually promote fibrosis to TGF-beta. And so here we show that even in the small samples, in a small cohort, these markers actually are significantly higher in ART suppressed people with HIV compared to HIV negatives. It's kind of like putting everything together as far as fibrosis and inflammation. And so this is an ongoing study with more data to come. And so work like this only happened thanks to our amazing study participants. And thank you to all of the collaborators. It takes a large team of individuals to make all of this scientific work come together. Thank you for your time, and I'm open to any questions.
Great, thanks, Deanna. Great talk. We have a couple minutes for questions. Feel free to just unmute yourself or put something in the chat, and I can call on you.
Hey,
yeah, wants to ask something.
Hey, I was actually wondering if there was any suspected mechanism linking the different classes of regimens to the different outcomes. Like, why are NNRTIs? Why do they look better?
We haven't looked as far as what we're showing in a study. We haven't looked at the data as far as the different ART regimens that people are on, but that's definitely something that I'm planning to look into.
Thanks. Yeah, it's fascinating, whatever that is.
Yeah, Steve, go ahead.
Deanna, fascinating. This is really important stuff.
Thank you.
But you said, I thought, that the visceral fat that accumulates is the most pathologic, particularly with regard to diabetes, and it was fibrosis, inflammation causing fibrosis, and the visceral fat leading to these complications. But you measured subcutaneous fat in terms of fibrosis.
Yes.
And I assume that's because it's more accessible, but what's the relationship between subcutaneous fat and the more pathologic visceral fat in terms of fibrosis?
Right. So that's a good point. And we do have, we are only able to collect visceral fat if someone is undergoing abdominal surgery or bariatric surgery. So that's not the case in this cohort. But the idea is that if you develop significant amount of fibrosis in the subcutaneous fat, you're not going to be able to expand the adipose tissue. You lose that plasticity. And so by losing that plasticity, all of the fatty acids and triglycerides actually are forced to go elsewhere. And so that's what's going to lead to expansion of the visceral adiposity. And then you have fat going into the liver, which leads to NASH. So it's kind of a surrogate way of looking at what's happening in the visceral adipose tissue. And I didn't show a graph that we put together, but actually this fibrosis in the subcutaneous adipose tissue measured by hydroxyproline actually correlate nicely with visceral adipose tissue in this cohort and also in our previous studies. So this is a way to kind of get to that.
Thank you.
Okay, should we turn it over to let Deanna introduce Paul? Great. So Deanna.
Okay. Well, so it is my great pleasure to introduce our speaker today, Paul E. Sachs. Dr. Sachs is the clinical director of the Division of Infectious Diseases at Brigham and Women's Hospital and a professor of medicine at Harvard Medical School. He holds the Bruce A. Beal and Robert Lee Distinguished Chair in Infectious Diseases. Dr. Sachs, sorry, 1 second, I lost. Oh. I apologize. I don't.
You know, you can skip the rest. That's
yeah, but I'm trying to. I don't know why I cannot.
That's all right. Just want to make sure that people can see my screen.
There you go. Yes. So sorry about that. So Dr. Sachs received his MD from Harvard Medical School, did his residency in internal medicine at Brigham and Women's Hospital, and a fellowship in infectious diseases at Massachusetts General Hospital. Dr. Sachs needs no introduction for HIV clinicians, as he had led several key trials on antiretroviral drug efficacy and remains one of our field's foremost experts on ART management and toxicity. He also maintains a highly influential blog on HIV and ID issues that has been viewed millions of times. He has also been an important voice of recent combating misinformation on Twitter and staying true to the science during the COVID-19 pandemic. Dr. Sachs is an exceptional communicator, has a great knack for distilling the most critical insights from research to inform clinical practice. Most recently, he has later contributed to several recent studies evaluating the impact of ART therapy on weight gain in treated HIV infection, which is a topic that he will address today. His talk is entitled Weight Gain in HIV Treatment, Still a Lot to Learn. So please join me in welcoming Dr. Sachs. It is a pleasure to have you here, and we're very excited for your talk.
Well, thank you so much, Deanna. I'm really, it's really an honor, and thanks to Monica for inviting me. I'm delighted to share what I've learned about this topic. I have to say that the title, Still a Lot to Learn, really reflects my knowledge of it. And Steve Deeks ahead of time was saying, I hope you're going to solve this problem. And the answer to that, unfortunately, is I will not solve this problem. So I have some disclosures. I show them here. So let me start with a case presentation, which will probably be very recognizable to you from your own practices. And then I'll talk about the clinical data linking HIV and its treatment to weight gain. And I hope that maybe by presenting it today to a group of experts like you, we'll come up with some answers that are better than these Wonder Sauna hot pants. All right, so this is a 58-year-old woman, and she is living in Boston now, but she's originally from Zimbabwe, and she was diagnosed in 2007 with thrush and advanced HIV disease, and she had a BMI then that was fairly high. She was already overweight, and she was treated with TDF-FTC efavirenz and rapidly achieved viral suppression. Her weight increased a little over the next 5 years, but not very much. Never heard a peep about it. This was her weight that she was comfortable with. And then what happened is that we started switching her treatment, and these are the switches she's had. She went on to single pill elvitegravir, cobicistat, TDF, FTC, and then TAF version of that, and then most recently dolutegravir, lamivudine. And now her weight is up to 91 kilograms. Her BMI is 41. She feels bloated and unhappy. She wants a change in therapy to help her lose her weight. So with this case as a background, I want you to think about this because, you work these people up for causes of weight gain and you never find anything, although I shouldn't say that. Occasionally someone who's on a protease inhibitor is getting exogenous steroids, but most of the time you don't find anything. So what are our options now? We can continue what she's on, switch her back to TDF-FTC efavirenz, switch to something else. And I don't know the answer to this question. I could pause or I can invite input from this very experienced group in patient management. In fact, I could ask Monica, what would you do in this case?
We are really thinking a lot about going back at times to TDF and to efavirenz. And it is not that we didn't believe the renal bone after quite some time with TAF that it was safer than TDF, but the metabolic effects of possibly being linked to TAF are making us go back and think about TDF way more than I thought that we would at this point in our clinic. Efavirenz, maybe I would say we're not yet going back to that, but TDF is coming up a lot. Yes.
Well, that's an interesting strategy. And I know that there are obviously studies that are going to look at that, and I'll be summarizing some of those. But I want to tell you that we don't yet have any evidence-based guidelines for this problem. And that's just a state of the facts right there. We simply don't. And what I'm going to do now is show you at least what I think are the best data comparing people with HIV to people without HIV and their weight trajectories over time. I was surprised to see that this paper hasn't been published yet. And it's the Kaiser data that were presented a couple of years ago or a year ago, looking at people with HIV in orange starting treatment versus people without HIV in blue and following them over time, years from baseline. Great study, incredible control. Look at the size of the control group. We've got, 50,000 people in the HIV negative group and 3,000 in the people with HIV group. And what is evident here is that the slope heading upwards is steeper for people starting ART than it is for HIV negative controls. And you could say, well, that makes sense. They're starting ART and they're getting healthier. Now, this is a study with some limitations. I put them on the slide. And probably the most important is that this Kaiser cohort is 85% male. But there's another group that's just presented information like this that has a group that's about 40% female. So I think this is applicable. Now, with what's plainly happening in our world is that we have obesity increasing everywhere. And if you look globally, where is obesity most prevalent? You see it, interestingly, a difference in region. And it's in North American men and in South African women. And one of the things I think is fascinating about this is that we tend to lump at least in discussion of this, Africa together. But in fact, if you look at East Africa down here is one of the leanest places in the planet. So this is happening absolutely everywhere. In fact, when one of the first raltegravir and obesity studies came out, one of the things they criticized it was that it was a temporal association between use of raltegravir and obesity, and the prevalence of obesity in Brazil had increased substantially over the 10 to 15 years that the study had followed. So let me shift now to talk about the paper that Diana mentioned in her introduction. This is a pooled analysis of weight gain in 8 randomized controlled clinical trials. It's treatment-naive people in Gilead-sponsored studies, and they started treatment between 2003, so there's a zidovudine arm in here, and 2015, and it had over 5,000 participants, 10,000 person-years of follow-up, and then in addition to just describing the changes, there was also multivariate modeling to look at the relationships between the demographic factors, the HIV disease characteristics and ART components, and weight change following ART initiation. And I have to hand it to them for this. They brought a group of us together to look at these data. They shared all the demographic and weight data from their clinical trials. They communicated with us through the entire time without any, at least I don't think, any obfuscation or misdirection. And I found it a very good model for industry academic collaboration. And I actually contrast this with, we really haven't seen that with the other industry-sponsored clinical trials to the same degree. So anyway, what did we find in this? These are people starting therapy now. We found that disease status at baseline was the strongest predictor of weight gain, with more advanced disease being the people who gain the most weight. And this is, again, not surprising. This is they return to health phenomenon. But there are a bunch of other things that we're seeing here. You can see viral load and race and sex are all here as well. I actually think that it's interesting that these all panned out because they've subsequently panned out in multiple studies of starting therapy, but not all studies of switching therapy. So what about the specifics of the antiretrovirals themselves? So there, the story is that the integrase inhibitors seem to be the biggest culprit in HIV ART-related weight gain, with a big difference between the integrase inhibitors, the protease inhibitors, and the NNRTIs. And then when you look at the integrase inhibitors individually, you can see that bictegravir and dolutegravir appear to cause or lead to more weight gain than elvitegravir covacistat. And then among the nucleosides, there's a clear difference between tenofovir alafenamide and tenofovir disoproxyl fumarate. But I wanted you to just also take a look at one of the curves in this study, which is the zidovudine curve, because here people don't gain weight. And this is actually potentially a toxicity signal. Now, you have to be old like Monica and Steve and I to remember using zidovudine, but it was kind of a nasty medicine. And I want to just mention that zidovudine has quite a lot of gastrointestinal toxicity. So while we are accustomed to looking at weight gain as a problem in the United States, where we have an obesity epidemic, in fact, here I would argue that people starting antiretroviral therapy should gain weight. And the question is, are they overshooting? Not should they, not is weight gain per se a problem. So one thing that this study also importantly showed us is the following, and this is brings me to some important limitations of anecdotal evidence. When bictegravir was released, I had a lot of people on TAF-FTC, the dolutegravir. That was our most common regimen by far, and including many who had gained a lot of weight. And I actually switched a patient to bictegravir FTC TAF, shrugged my shoulders and say, maybe you'll lose weight. And lo and behold, he did. But that is the limitations of anecdotal medicine, because he actually intensively changed his diet and exercise at the same time he switched to bictegravir FTC TAF. And that weight loss, unfortunately, was temporary. But there was a brief moment there where he and I were both congratulating ourselves on this brilliant switch. In fact, bictegravir and dolutegravir are quite similar. And then points for the people who can give me the origin of this meme. The data also come from prospective observational studies. This is a study that the NA Accord did. They got a lot of attention because the numbers are so big. But again, you see the difference between the 3 integrase inhibitors. I have to say, one of the biggest surprises in HIV medicine for me over the past 10 to 15 years was that the integrase inhibitors have this signal. When they first came out, when raltegravir first came out, our assumption was that with its very kind of clean metabolic profile from the lipid perspective, that none of this would be a problem with the integrase inhibitors. And in fact, ACTG 5257, which compared raltegravir with darunavir versus atazanavir, in fact, that raltegravir arm gained the most weight, had the most subcutaneous and visceral adiposity, and actually didn't have as good cardiovascular profile as the atazanavir ritonavir, which was a surprise to many of us. So that's some data on starting therapy. And one could look at that and you could sort of make the conclusion that the integrase inhibitors in TAF cause weight gain. And I want to just say that it's not so simple. So let's take a look at a non-TAF study that was just presented. This is from ID Week. This is a STAT study, which is basically newly diagnosed patients going right on dolutegravir lamivudine. And the virologic outcome of this study is of some interest because they didn't have baseline information. So it shows you can use dolutegravir lamivudine if you want for rapid start, although I think most of us wouldn't do it. But they ended up having virologic success, no resistance. Some people had to switch because of M184V or hepatitis B, but most didn't. But the weight changes were really quite something in this study. And again, if you look at this is a non-TAF study. You can see that the weight changes are very, very similar to the dolutegravir and bictegravir studies with TAF. And again, low CD4 cell count people gain the most weight. And this does, again, argue that some or maybe most of this weight gain with ART initiation is, in fact, a good thing. Now, I think the strongest evidence that weight gain from ART initiation is a good thing. It comes from my very brilliant clinical trialist colleague, Shaheen Lachman's study, which is Impact 2010. Now, Impact 2010, just as a reminder, were women starting ART during pregnancy. They were allowed a little bit of ART before starting, but not much. And they then were randomized to one of 3 different treatment arms. One of the treatment arms was a control arm of TDF-FTC efavirenz. One of the arms was TDF-FTC dolutegravir, and the third arm was TAF-FTC dolutegravir. So this is the first prospective study looking at TAF use in pregnancy. And then there were 2 endpoints of great interest. One was virologic suppression at delivery, and the other was safety. And what I'm going to focus on in the presentation is the adverse pregnancy or safety outcomes. So here's the key finding. Well, I'll mention the virologic outcome. The dolutegravir arms were superior to efavirenz for viral load less than 200. But if you take a look at this composite endpoint of any adverse pregnancy outcome, you can see that dolutegravir plus TAF-FTC associated with the best pregnancy outcomes, the least likelihood of these 2 outcomes in particular, preterm delivery and small for gestational age. And then a further analysis was then done looking at the relationship between weight gain during pregnancy on these regimens and the outcomes. And what the data showed was that the weight gain was greatest for dolutegravir plus FTC TAF. No surprise, right? You're used to that. But that this was also closest to what the Institute of Medicine recommends for weight gain when women are pregnant. So it was at 0.38 kilograms of weight gain in the 2nd and 3rd trimester. It recommended is 0.42. And then if you had people who had insufficient weight gain, that was most likely to be in the efavirenz arm, and then correlating weight gain with decreased risk of any adverse pregnancy outcome was strong. So that the women who gained the most weight were actually the ones least likely to have an adverse pregnancy outcome. So what this suggests is that some of this weight suppressive effect of TDF-FTC efavirenz may not, in fact, be a healthy one, because here in pregnancy, the weight suppression is actually associated with worse outcomes. So you're probably familiar with these pharmacogenomic studies looking at efavirenz and weight loss. And I'm going to just mention them because they're very interesting, but a little bit perplexing. So ADVANCE is this randomized clinical trial looking at TDF-FTC efavirenz versus TDF-FTC dolutegravir or TAF-FTC dolutegravir, a large study done in Africa. And they did genotyping for CYP2B6 in some of the TDF-FTC efavirenz participants, and they categorized them as extensive, intermediate, or slow metabolizers. And when you look at weight changes from baseline, the people who were slow metabolizers and had the highest efavirenz levels actually didn't gain much weight at all, whereas the extensive metabolizers and had low efavirenz levels gained the same amount of weight as the dolutegravir arm. Now, this is just looking at the TDF-FTC arm, but it is quite striking. And so this observation that people with high efavirenz levels gain less weight was then also found in an ACTG study. And here they included both people switching as well as people randomized in ACTG 5202 to receive efavirenz and then randomized to a TDF or a bacavir. And what this complicated figure shows is that the weight suppressive effects of efavirenz, which are just seen again in the slow metabolizers, are really only seen with TDF. And I got to tell you, this is a very surprising finding. So surprising that I'm just going to quote the abstract and say, the difference by concomitant nucleoside analog is unexplained, and I have no idea why this is. So you know, I realized that when Monica said she might switch the patient back to TDF, she was cautious about switching back to efavirenz, but it does appear that to get that efavirenz effect, it has to be with TDF, and we don't really understand this at all. At least I don't, and maybe if there's a pharmacologist in the audience, they can explain it for me. So to summarize on the treatment-naive studies and weight gain, I don't know whether weight gain on antiretroviral therapy is an adverse effect or a return to health or both. And the question then is, if it's an adverse effect, how are integrase inhibitors and tenofovir alafenamide related mechanistically? I can't figure that out. I just put the figure from the ADVANCE study on here. And then if it's a return to health, why do TDF and efavirenz regimens cause weight suppression? And why only efavirenz with TDF and not a bacavir? Well, you know, one place to look would be switch studies and PrEP studies. And that's where we're going next in this talk. So let's take a look at TDF and weight changes in people without HIV. And this is Andrew Hill's group. And this paper was presented at IES this summer, and then now it's in Press at AIDS. And they did this systematic look in the published literature on where the randomized controlled trials where people get TDF-FTC or TDF alone to a control in HIV negative individuals. So obviously a lot of these studies, all these studies are pretty much PrEP. They could have looked in hepatitis B, but they didn't. And they had one study in their analysis that also looked at TDF-FTC versus cabotegravir. And they decided not to include TDF-FTC versus TAF-FTC because obviously very similar components, but I'll show you some comparative data with that study also. So here are their results. If you take a look at this forest plot, let's focus on the top. These are in versus placebo. Weight loss with tenofovir disoproxil fumarate is clearly demonstrated. It's also demonstrated versus cabotegravir, and then there's a significant difference overall. So what they concluded, so they concluded that this is suggests that TDF has a weight suppressive effect in HIV negative people. I don't think you don't actually need to do the analysis to say that. It's pretty clear because this is compared to mostly to placebo. And then in the Discover studies, so this is IPREX. So we've already seen IPREX in the Andrew Hill analysis, and this is the placebo arm in IPREX, and this is the the TDF FTC arm. And then if you take a look at the TDF versus FTAF arm, this again is the FTDF arm, looking very similar to IPREX, and this is the FTAF arm. So FTAF or TAF is associated in this study in HIV negatives with more weight gain than TDF, or alternatively, TDF is associated with weight suppression in this study. So to conclude on the HIV negatives, people without HIV have weight suppression on TDF compared with placebo, cabotegravir, or TAF-FTC. There is a literature on hepatitis B treatment that shows the same thing. Why it's happening is not clear. There's a study in the study they looked at GI side effects, and clearly some of them are more common with TDF, but they tend to wane over time. We definitely need more research on the mechanisms of action, and we have to understand the implications for people with HIV. So then let's also move on to switch studies. And the first I kind of heard about this switch issue was, I wrote about it in this blog that Deanna kindly mentioned. It's on a link, a bunch of ID links that I found interesting, including microwaving your sponge increases the growth of harmful bacteria, and that ceftaroline may be an option for severe MRSA infections. But then down at the bottom, you see, does switching to dolutegravir-based regimens cause weight gain? This is the second published paper implying such an effect, and I linked the first one. It's hard to come up with a plausible mechanism. Still, weight gain in HIV therapy in general remains a knotty, unsolved problem. That's basically my saying. Even back then, I didn't know what was going on, but I did get to put a picture of SpongeBob SquarePants here. I snuck it by the New England Journal of Medicine people who are very scared about copyright protection, so I don't know how they let that on. But this is the first paper right here, historic, going back. A French group, people who were switching to dolutegravir-based ART, mean follow-up of under a year, the weight gain was 3 kilograms. Look at that. And the effect size, interestingly, was greatest for those switching to abacavir 3TC plus dolutegravir. Remember that they're losing now the TDF effect, because if they're going on abacavir 3TC dolutegravir, they're probably stopping TDF, FTC, efavirenz, and that was seen in multiple studies in hindsight. So then Christine Erlandson got to take a look at these randomized clinical trials, and this was a large group of patients. And so they're all suppressed, they're all very healthy, and then they're 4,000 randomized to switch, 3,000 to continue their baseline regimen. And when you take a look at the trajectories, you can see that if they're coming off of efavirenz, switching to rilpivirine, they gain weight. And so this gets to this whole class issue. Can you lump in all the classes together? It's tempting to do that, but clearly rilpivirine is associated with weight gain in these switch studies. And the same was true with switching to elvitegravir. Note, if you switch from nevirapine to elvitegravir, you don't get this change that's about the same. So therefore, it's not a class effect. It's basically one that just, switching some treatments leads to weight gain, and it might be withdrawal of the suppressive agent. And then I want to mention, again, the nucleosides. If you take off TDF or abacavir and switch to TAF, you do gain weight. Now you take off TDF and go to TAF, you gain more weight than if you take off TDF and go to abacavir. But then when we did a multivariable analysis on predictors of significant weight gain, this is what fell out. First, the BMI category. Those who were underweight gained more weight, and those who were younger gained more weight. And then of the ART strategies, the one that I think we've all noticed is switching off TDF to TAF. That's the one that comes up as associated with 10% or greater weight gain. And then also efavirenz switches, both to rilpivirine and to elvitegravir cobicistat. Now, we've also learned recently a lot about other switches. And we've learned from the tango and the salsa studies. I thought it was very funny. Someone told me they were surprised that the salsa study was named after this common condiment at Mexican restaurants. What they forgot was that these are both dances. It takes 2 to tango and 2 to dance. And let me just present the salsa data because they're the newest data. This is a study that looks at people who are on any baseline regimen that are suppressed and switches them to dolutegravir lamivudine or continues what they're on. It's an open label study. Not surprisingly, it works virologically. I'm not going to go into that. But why am I focusing on this trial? I'm focusing because the baseline regimens are going to turn out to be very critical for this weight issue. Look at this population. 40% or so are taking TDF, and a bunch of people are taking NNRTIs, and most of them are taking efavirenz. And as a result, when you look at the virologic results, it works fine. I don't want to focus on the virologic results. I want to actually focus on this particular finding, which is that drug-related adverse events were substantially higher in the dolutegravir lamivudine arm than the continued therapy. This is partially ascertainment bias. Remember, they're stable on their regimen. They're switching to something new. If they have an adverse effect, they're going to blame it on their new medicine. So I don't think that's really can make too much of it. But what we can see is that in this study of people switching to dolutegravir lamivudine, that one of the most common reported drug-related adverse events was weight gain. And that is shown at the bottom, the absolute amounts, 2 kilograms in the dolutegravir lamivudine group versus 0.6 in the continued therapy group. To go to the dolutegravir lamivudine query, because this comes up in our clinic all the time, can I make this person lose weight by switching them to this regimen? I don't think there's any concern so far about virologic suppression. But what about switching? Will it improve metabolic, renal, or bone parameters? Well, it depends on what they're taking at baseline. Will it alter their inflammatory markers? There's a whole debate in the HIV world about this. I am agnostic right now. But what about will it lead to weight changes? I am actually think a lot of this depends on what you're taking at baseline. And there really is no evidence now that weight loss occurs if you stop TAF, unless it's replaced by TDF. I think that's kind of the message from these dolutegravir lamivudine switch studies. So let's go back to our case and then we'll wrap up. Here is the reasons why she has gained weight with these switches. She started on TDF, FTC, efavirenz. She then switched to an integrase inhibitor. She then switched the TDF to TAF, and then she switched to a more weight-inducing integrase inhibitor, a weight-associative integrase inhibitor, dolutegravir. And so that's why she is having difficulty with weight gain with these ART switches. I'm going to tell you is that when I asked about how to manage it, Monica said, we're thinking about doing some switches. Certainly that happened in this case report. I get to highlight a case report from our journal. This is a patient who started therapy on TDF, FTC, efavirenz. You'll notice that his weight trajectory was flat after starting ART. One could argue that's a good thing, or one could argue that's not a good thing. Whatever, all I can say is when he switched to elvitegravir, cobicistat, FTC, and TAF, he gained 23 kilograms over 4 years. Wow. And then he switched back and lost the weight. This is about the highest form of evidence we have for ART changes in leading to weight loss. I hate to put one case report here, and I know Christine Erlandson is collecting cases for a little observational study she's doing, but there isn't a whole lot out there unless you guys have something in the works that you're looking at. Instead, we can encourage people to enroll into these clinical trials. As you know, the ACDG is doing this study with doravirine now. It's taking people like this man who gained a lot of weight quickly on his integrase plus TAF containing regimen, although he would not have been eligible because it excludes people on boosters, and then randomizes people to doravirine and staying on TAF, or doravirine and switching to TDF, FTC, or continuing what they're on. Now, this study has been a bear to enroll. Actually, we have not been able to find anyone who's willing to do it yet. And there are a lot of people who are excluded just based on the baseline, the inclusion-exclusion criteria. I'm very curious to know what your experience has been. So the study team is very concerned that they're going to have difficulty enrolling it. But that's looking at doravirine, for which we have only some very indirect data from the doravirine versus efavirenz switch study, showing that it's probably not as weight suppressive as efavirenz, but we'll see. And then there's this study that's being run by by Janssen, the makers of darunavir. I don't know where this study is in terms of enrollment or outcomes. We haven't seen the data presented yet. At least I haven't seen it presented yet. But this looks at people with weight gain on Integres plus TAF regimen, and then actually switches them to darunavir. So we'll see. One thing I really liked, which I highly recommend, is this editorial that Sarah Perez wrote in CID. You know, the challenge for the clinician is to translate these findings into clinical practice at a time when many questions remain about the clinical implications of this weight gain. We must incorporate counseling and anticipatory guidance regarding weight changes when initiating ART, and continue research to evaluate the mechanisms, consequences, management, and prevention of weight gain following ART initiation. I completely agree with this. When people start ART, they definitely should be told this is going to happen. Most of it is a good thing. Some of it might be overshoot, so beware. You know, we live in an obesogenic society, and by being in that society, we are going to see our patients gain a lot of weight on antiretroviral therapy. Now, this is my summary slide, and then I hope we'll have time for questions. We've already mentioned a lot of these things, and I'm not going to belabor them. I do want to mention here that the medical consequences of weight gain are uncertain. And I deliberately didn't put studies in here on this topic because either they're short-term and you don't really see much in the short term, or they show something, but they show exactly what you'd see in HIV negative people. I think that this is almost inevitable, that this weight gain is going to have adverse consequences, because that is what happens in people who are HIV negative. If they gain a lot of weight, they have adverse consequences. And so really we have to figure out, is it worse in people with HIV? I guess, Diana, your research suggests it might be. But anyway, I hope we can continue to research this. This is sort of a difficult problem in HIV medicine. And again, thanks for allowing me to summarize the data.
Paul, thank you so much for that. And I think what was profound about this talk for me was how recent the data is that you presented from ID Week. There were a lot that we knew, but you unraveled also profoundly what we would have to do in terms of comparison TDF and TAF. And then what you just presented about the favorance that has to be with TDF was startling, because we all remember what happened with the favorance and why we rejected it roundly in this country. But we are seeing the consequences of what's happening with weight gain, also with the pandemic and everything else every day. And we met with ACTG yesterday and all we talked about was weight gain. Actually, so much of it was weight gain and the behavioral aspects of trying to combat this. So I think we have a number of questions. I'm gonna actually start with Peter and then have Aisha unmute if she's willing to, and ask her a very good question here.
Paul, that was outstanding. A great review of a really complicated area, and I agree that there are more questions than answers. I wanted to touch on this really peculiar tenofovir favrins interaction that Monica also just referenced. There is some concern that even the modern nukes, TDF and abacavir, may have some mitochondrial toxicities, not like AZT like in the past, but more subtle. And Grace McComsey had published a paper in JID about almost 10 years ago now, from an ACTG study showing that in people randomized either TDF or abacavir, both groups lost mitochondrial DNA in adipose tissue. And the interesting thing was that there were different mitochondrial enzymes that were affected with tenofovir and abacavir. And I wonder whether there may be a clue in there that might link into this, because I'm not aware of any pharmacological interaction between tenofovir and efavirenz, or abacavir for that matter.
Yeah, it's a real mystery. I was very surprised. I contacted the statistician on that paper and I said, why aren't you seeing this efavirenz effect with abacavir? She says, I have no idea, but we've ran the analysis many times, and so it's very surprising.
I'm hoping actually that I
A
just
pharmacologist is just turned on her camera.
I just saw a pharmacologist put herself on video, and I'm very hopeful that she can maybe reveal. So before we go to the other couple of questions, Fran, do you have Fran Awika, clinical pharmacologist extraordinaire, any thoughts on what we just talked about?
Well, I don't know the literature nearly as well as Dr. Sachs does, but I did do a quick look, and I have to reiterate what Peter said about the mitochondrial toxicity. And my quick look is that tenofovir is more of a culprit in that sense than abacavir, and that abacavir has actually been associated in one study with less weight loss, I should say. I think greater weight gain than tenofovir. So I think there's a difference between those two drugs, and that might explain why you saw with efavirenz and tenofovir an impact while you didn't. Abacavir might have been countering the efavirenz effect.
But of course,
I think that's the simplest explanation.
Yeah, I mean, this is of course now suggesting that these are toxicities rather than a benefit. You know, that's
Right.
what the impact study is really kind of telling us, is that this weight suppressive effect of TDF and efavirenz together is not a healthy thing for pregnant moms.
It definitely isn't. And you saw the benefit of weight gain in the pregnant moms, but yet we do know that weight gain can't all be great, right?
Yeah.
But that maybe the effect of weight gain in pregnancy, just the fact that they have weight at all, it counteracts the negatives, but there's a negative piece to that as well.
Yeah.
I'm sure. It's complicated.
I think this actually leads to a question that Aisha asked one of our fellows, which is whether the TAF plus INSTI weight is primarily visceral, subcutaneous.
It's both. It's both. It's generalized. It's not like we used to see those horrible cases of mostly visceral adiposity. It's actually a sort of generalized increase in weight, both subcutaneous and visceral. So it's more like weight gain that you would see just in people who are HIV negative. So
I see.
Thank you. That's helpful. I think I was just, as you mentioned, the clinical correlation or clinical significance is tough. I think when thinking about the rat's nest of dyslipidemia related to PIs and diabetes incidence and weight gain, how do you balance these with each category? What do we know about visceral adiposity with this weight gain? That's helpful. Thanks.
Yeah.
Sounds like it's still a question.
I hope you're not the actual driver.
Yeah,
I am. I'm not driving right now. I pulled over.
Diane, I don't know if you want to, Diane, unmute or ask about, but she asked, Diane Hovler asked about GLP-1 agonists, and what do you think, Paul, about how they're fitting in the current landscape?
I would ask Diana.
Yeah.
Lifestyle changes, do they really make a difference? Do people listen?
Well, definitely. You know,
I think someone is unmuted, and so I'm going to turn it over to, let me see who's unmuted, because we can always tell.
But the most important.
Okay, Diana, do you have a comment about GLP agonists?
Because
I do. I mean, I'm one of the attendants in the weight management clinic, and yeah, lifetime modifications are hard. And people listen to an extent, right? I mean, it's not easy, but that's kind of the first thing that we usually go for. But as far as GLP-1 agonists, I think they're a great medication, and I really prescribe it pretty often because it's a lot easier. It has a lot less side effects than the other medications that we use for weight loss. I think there was a study a while back on people with HIV, but I'm not aware of any recent studies. But it does work. I mean, we see at least a 10 to 15% weight loss in the general population, and I do have a good number of people in my clinic that are HIV positive, and it works pretty well. And also for people with NASH and fatty liver. So they're great medications. They're expensive. That's one of the issues.
Yeah.
One approach for weight management.
Yeah, I was going to share that I've just started using it more often. I have a lot of patients with fatty liver disease, and yeah, they seem to all lose weight. and their fatty liver disease gets better.
Yeah,
unfortunately, it's very difficult to get the insurance company to approve it. So
our one of our social workers was like celebrating with one of our patients about the weight loss that they had on these drugs. They're really amazing. So
one of my patients was in tears last week.
Yeah.
And it was just incredible.
I mean, on the other hand, you know, what we spoke about at the ACTG is the need for behavioralists. And there's a new behavioral science working group for lifestyle modifications. And I know that's hard, but exercise and nutrition, it's been so little of what we do in medicine, I think. And so there's that too. Remember, exercise. There are some other questions that have appeared, which is from Phyllis Tian, Paul. How does lean mass increase factor into the weight gain?
So lean in people starting therapy, lean mass increases in a healthy way. So that's part of the weight gain. Absolutely, it's not all fat. The thing that I think comes up repeatedly in these discussions are not the people who gain some weight, but the people who gain a lot of weight. And can we learn something from the outliers? And I think that's probably the patients with advanced disease who start therapy, and we all know the situation, and then they've been on treatment now for 18 to 24 months, and they're like, I've never been so heavy in my life, and they're miserable. Initially they're excited that they gained the weight back, but now they're just, it came back too quickly, and that seems to be mostly fat. But some lean mass restoration is happening, and that's a good thing. So
I think there's just one final question that we have time for before 10:30, which is from Satish. I don't know if you want to unmute and ask Satish. We did have some data from Rafi on cabotegravir, but this is, yeah, go ahead, please.
Oh, yeah, just a simple question. I was just wondering if any of the long-acting ART agents, if there's any data on how they intersect with weight gain or adiposity.
Right. It depends what the comparator is, and the cabotegravir in the initial study of HIV negative people who are at low risk of HIV, just a sort of exploratory analysis, there was no change. And what's been seen now is when the comparator is TDF, there is more weight gain in the cabotegravir arm. So it's the TDF is probably suppressing weight, and cabotegravir is either neutral or integrase inhibitors are doing something. There's this theory about off-target effects of integrase inhibitors, but I have not seen that confirmed in any way. Maybe someone else knows.
Thanks.
Okay. Great.
Yeah, great. Thank you so much. That was incredibly helpful in terms of the most recent data. I think the problem sometimes with these weight gain talks is that we just see the advanced study, and there has been so much since, and it is subtle and it's hard and it's complex, and but it's the issue of the day. And so thank you so much for putting this so cleanly together for us. Deanna, thank you for your excellent talk about and your presence at our university as an endocrinologist. We really need you. And thank you again. And I'm going to ask people that clap.
Thank you.
And Paul, we will
learn
from. Thank you so much, Will, from what we learned from you.
Bye everybody.
Thank you.
Bye.
Bye.